Mobile extracorporeal membrane oxygenation, historical review and results. The presenter is Nick Tedford, and the sponsor is Sherry Faulkner.
Good morning. My name is Nick Tedford. I would like to thank the American Academy for giving me the opportunity to present this paper, Development of Mobile ECMO, Historical Review and Results by Faulkner et al. This presentation describes 3 phases of the mobile development, the development of Arkansas Children's Hospital Mobile ECMO program and its results. The first phase began when the Arkansas Children's Hospital ECMO Center opened in 1989 with a 3-bed capacity that was aimed at treating all types of ECMO patients. This map shows states which had ECMO programs. However, not all centers treated different types of patients. There are 2 goals of mobile ECMO. The first goal was to stabilize and rescue patients. The second goal was to educate doctors about the appropriate time to send patients to the center so that they would not need mobile ECMO. Now, to make these goals a reality, several things had to occur. The first thing that had to occur, that had to be done, was to form a mobile ECMO team. Next, an aircraft had to be identified which was capable of transporting the team and all the equipment. It was decided that the UH-1 and Army helicopter would be the best choice, but before it would work, the ECMO equipment had to be modified to fit into the aircraft. Once all this was accomplished, then it was time to let everyone know that Arkansas Children's Hospital had mobile ECMO. The first mobile ECMO team was transported to the departing hospital by the Army helicopter, but had to return in a van because of unforeseen circumstances. The second patient was also rescued by the helicopter, but unlike the first, this patient was transported back to Arkansas Children's Hospital and the helicopter. Both of these patients survived transport, but unfortunately did not survive the disease. The third mobile ECMO was a neonate diagnosed with group B strep and was unable to be transported conventionally. Once again, the mobile ECMO team flew out to the location of the patient and returned with this patient on an ECMO and the Army helicopter. I've heard people say that 3rd time's a charm. Well, in this case it was, because this patient was successfully weaned from ECMO and survived. Shortly after this historic event, the Army helicopter and staff were deployed to Saudi Arabia when the first Gulf War began. At that point, another type of transportation had to be found to continue mobile ECMO. Fortunately, a Learjet was located here in Florida, and that ambulance made it possible to continue transporting all types of patients as well as mobile ECMO team. During this time, few children's hospitals offered cardiac transplantation, the ability to reach and rescue patients needing a heart transplant, and then transporting them on ECMO to a center to offer cardiac transplant was achieved with the use of a Learjet. Realizing mobile ECMO was here to stay, this was the beginning of the 3rd phase, along with the upgrading of the hospital's transport abilities, which resulted in the purchase of a helicopter large enough to transport mobile ECMO. The mobile ECMO team now includes a larger group of people that are trained to perform mobile ECMO. And never knowing how long the transport will take, the team is always prepared to stay out for long periods of time. The results from the beginning of the mobile ECMO program show that all 109 patients survived mobile ECMO transport. 68 of those patients were weaned from ECMO, and 61 survived the discharge. ECMO, and especially mobile ECMO, is an expensive undertaking. There is an increase of risk not only to the patient, but also to the ECMO team. The top left picture of the mobile ECMO team. The bottom left picture shows the baby on ECMO. His head shaped to allow for IV fluids and the ECMO cannula in his neck. The top right shows a mother holding her son for the very first time. As I understand, there were no dry eyes in the room. The bottom right picture is a reunion with the Mobile ECMO team, helping to celebrate her big first birthday. It's amazing to see a patient so sick that he had to be placed on a life support system, his head shaped to prepare for IV fluids, and his ECMO tubes placed in his neck, which resulted in carotid ligation. Survive, grow up, celebrate his 17th birthday, and yes, even grow his hair back. Thank you for saving my life, ECMO team.
If there's one hero here, I want to, well, there's actually several, but I want to introduce you to the lady that allowed us to come and take her child away before she ever held him, and had courage in us and supported us. Dana, would you stand up? Miss Dana Tedford. We feel like, and I've told Nick this many times, this was the first mobile ECMO survival in a UH1. A lot of people had come before, Devin Cornish, Dr. Bartlett's doing ECMO, but this was the door that opened for the neonates when we went out and we were able to get him back in. And it also opened the door for the military to use ECMO as a means of rescue during the Gulf War, and that was why the 374th Detachment was moved into Saudi, and we were working in conjunction with General Powell to have the ability to get our soldiers on ECMO if there wasn't a German warfare. So I would like to recognize the 374th, which has been disbanded. I would like to recognize General Powell, Colonel Powell, who worked with us, and especially I would like to recognize Senator Dale Bumpers, who stood behind us and led the charge. Thank you very much.
Thank you, Sherry and Nick and Mrs. Tedford. That was